consider doing a pharyngeal anastomosis, we would probably do a pharyngeal anastomosis or repair of the pharynx whenever we perform a pharyngectomy in a patient. Yeah? So a patient with a hypopharyngeal tumor, we perform a partial pharyngectomy, we need to re-anastomosize the pharynx, then we have to do it in this group of patients. Another common indication is patients with pharyngectomy. Why? Because the posterior part of the trachea forms the anterior wall of the pharynx. So when you do a total laryngectomy, the anterior part of the pharynx will be automatically be resected. So you need to form a neopharynx by performing a pharyngoplasty in these patients. Of course, in the patients with trauma, they may also injure the pharynx. Therefore, in this group of patients, we have to switch the pharynx. A lot of you all are wondering, when can we primarily close the pharynx, or when do we need to use a flap? Now, there's no hard and fast rule, but in general, we look at how much of residual pharyngeal tissue that you have. Okay, if your residual pharyngeal tissue is about 1.5 centimeters when it's relaxed, then it's enough to anastomose the pharynx to form a tubular structure. When you stretch it, they say it's about 2.5 centimeters. Certain books, if you read Scott Brown will tell you that if there's approximately 50% or more pharynx still being preserved, then you can anastomose the pharynx and close the pharynx without using a flap. Okay? But then a lot of people don't like this 50% concept because it's very hard to gauge what's 100% in the pharynx because you have an already resected pharynx there. So it's very difficult to gauge 50%. It's just agak-agak, it's just guessing. So a lot of people use 1.5 centimeters relaxed of pharyngeal tissue available, or 2.5 centimeters when it's stretched. So when you have adequate amount of pharynx, then you can close it primarily. Why you can't close a pharynx if there's no enough tissue? Why can you not possibly close the pharynx? Otherwise, if you still try to possibly close the pharynx, you will not have enough of tissue to approximate, so you still have a gap, or the tension will be too high and it will break, or the patient will have very severe dysphagia because the lumen is so small, or all will be stenotic. We try to force it close. And so in certain cases, you have to consider using a flap. There are many flaps available. You can use a jejunal flap, you can use a pectoris major flap. That's a different topic altogether. Okay, so this is an example of a pharynx in a patient who has undergone a total laryngectomy. As you can see on the screen in front, there are many ways of closing the pharynx. Some centers will close the pharynx vertically, so if there's not much tension of the tubular structure, you can just suture it vertically and close it. But sometimes the defect is more of a T-shaped defect, so you have to close it horizontally and a vertical section to form a capital T over here. Yeah, we close this part vertically and the lower part horizontally is a capital T. Sometimes the defect itself is such a way that you have to close it horizontally in the middle and vertically again at the center. So that is a smaller T. Sometimes you just close it horizontally is enough. Horizontally alone sometimes is enough. So whether or not you close it horizontally or vertically or a combination of horizontally and vertically will depend on your assessment of the residual pharyngeal tissue during your operation. So this is the patient who's undergone a total laryngectomy. This is your tracheostoma, which you have brought up to your neck. So this is the pharyngeal defect. Okay, so this is what I wanted to concentrate on. Any questions so far? Yes. It can be either transverse or vertical because sometimes you want to close it like this, sometimes you want to close it like this. Yeah, so it doesn't matter. Yeah, so you have to assess it on the table. Yeah. Okay, so again, so whenever we suture the pharynx, we can either suture it horizontally or vertically, or a combination of horizontally and vertically to form a T. Okay, this is very important, next step. So whenever we close the pharynx, we want to close it in 2 or 3 layers. This is to prevent a leak. Where I was trained previously in typing with Mr. Hardip, I was trained to close in 3 layers. I understand some centers you are close in 2 layers. So this differs between surgeon and also centers. But ideally, if you look at all the three layers, you want to close your mucosal layer. So you catch the inner mucosa first. Once that's done, and then you catch the serosal layer, which is the second layer. And then once that's done, then you catch the muscle layer, which is the outermost layer to close the pharynx. Our main aim is to get a watertight pharyngeal closure to prevent leak, because you don't want saliva to be leaking. If saliva leaks, you're going to get a fistula, then you have a bigger headache to manage the patient. Okay? We all use absorbable sutures, which is vital. Why? Because you know to go back again and perform a suture removal on the patient. And okay, this is another technique which is very special for pharyngeal closure. Is we use continuous sutures, but we will tie a knot. I will demonstrate shortly on after 3 to 5 continuous bites. That means when you're doing a continuous suture, one bite through and through cut, second bite, third bite, then you tie a knot. 3 knots. Macam nak matikan suture, like how you want to tie a knot, you tie a knot. Or you don't cut the suture, you continue. 1, 2, 3, tie another knot. You continue again. 1, 2, 3, tie another knot. Then you continue again. So usually in pharynx closure, you want to be quick. So one surgeon will either start from the right side, another surgeon will start from the left side, and then you'll meet in the middle. And with every 3 bites, you tie a knot. 3 bites, you tie a knot. But for the ease of practice, maybe 5 bites and you can tie a knot, 5 bites and you can tie a knot. And then when you meet in the middle, just like your vascular suturing early on, then you can tie the sutures in the middle. Similarly, if you're doing vertically, so one surgeon will start superiorly, another surgeon will start inferiorly. Continuous 3 knots, tie. 3 knots, tie. 3 knots, tie from below, 3 knots, tie from below. Then you meet in the middle. Then you will tie the superior and inferior sutures together. Yeah? So this is how you do it. Why? Okay. Why do we tie although we do continuous sutures, why do we tie it every 3 to 5 knots? This is for security. So if one section of the pharynx breaks, the anastomotic site breaks, so at least it will not, because it's a continuous suture, if you have a defect on one part of the suture, the whole, it will affect the integrity of the whole continuous suture right from the start. So at least when you have a knot, only the 3 or 5 throws will break, will not break laterally or further. So this is to ensure there's integrity in your continuous suture. So if you want better integrity, you tie a knot every 3 sutures. If you don't have time, you tie a knot after 5 sutures. Okay? Alright, so our main aim end of the day is to make sure that the mucosal edges are inverted, right? So you want two mucosas to touch each other so that the healing is faster in the pharyngeal suturing. And towards the end of pharyngeal suturing, you will usually do a methylene blue test. So you'll pump or push methylene blue into the pharynx to see if there's any leak. If there's any leak, then you have to catch 1 or 2 more bites to close up the leaky area. Okay? Okay, so let's demonstrate. So we will begin at one end with a simple interrupted suture, and then we will use continuous suture. We'll knot it every 3 to 5, and then we will perform on the other side, and then we'll meet in the middle, and then we'll tie. Okay? So now I want you to concentrate in front. We don't have a pharynx, but we have a goat's esophagus. So assume that the goat's esophagus is your pharynx. The goat's esophagus is actually a bit more thicker compared to a human pharynx. Again, a goat's esophagus has got 3 layers. So you have your inner mucosal layer, you have your serosal layer, which is your middle layer, and you have your muscular layer. So all of you have received a tubular structure. Your muscular layer is the outermost layer that you can see. All right? So assuming this is my patient's pharynx, on my left-hand side is the patient's head, on my right-hand side is the patient's feet. I'm standing to the right of the patient, yeah? So I've done a total laryngectomy on the patient, so let me create a pharyngeal defect first. Blade. Blade's gone walking. Does anyone have a blade here? Can I borrow? No, I found it. Thanks. Yeah, thank you. first. So you can create a vertical defect. Okay, make sure you don't cut through and through, yeah? Just cut the outer structure first. Okay, so this is my pharyngeal defect here, as you can see. So I've got my inner mucosal layer, which is a very thin, sticky layer at the inner part. I want you all to see this. This is the inner mucosal layer. My friends behind, Thomas and also Akash, this is your inner mucosal layer. The middle layer over here, which is your darker white layer, is your serosal layer. And of course, the reddish bit is your outer muscular layer. So we will try today to do it in 3 layers, okay? So my defect today is vertical, so I can close it vertically. I don't think I need to close it horizontally. Okay, so I will use a white drill. You can all open up your white drill switches. Okay. So in my case, I will start inferiorly first. Okay. So now this is my mucosa. So before I start, I will identify the apex of my pharynx, right? So you see, this is my apex, right? So I will go about 0.5 centimeters away from apex, and I will put a knot. And I will tie this knot. This is just to secure my suture, because I'm going to use continuous suture. So find your apex, 0.5 centimeters away from the apex. You can tie a small knot. You can matikan your suture at the apex. Okay. So I'll go find the apex of the mucosa and put a knot there. So you can ikat mati over here. 1, 2, 3. Okay. The free end of my suture, I will attach it to a artery forceps. So my assistant will now hold the free end with an artery forceps to make it out. So you can tegangkan here, so that it's easy for you to pull the mucosa and also suture the mucosa. So your assistant will hold this. Okay, so you all can place the suture at the apex. You must use your pins to pin your pharynx down so that it doesn't move here. Can all of you all follow? Okay. Have all of you all identified your mucosa? Good. Siapa yang tak identify mucosal layer lagi? It's your innermost whitish layer, very very thin. Okay, so now I'm going to demonstrate the continuous part of my suture and how I'm going to tie every 3 to 5 ties. Okay, can you all please have a look, pay attention? Can you all see on the screen? Okay, good. Okay, so I already tied a knot at the apex, as all of you all can appreciate that. Okay, so as you can see, this is my mucosal layer, very thin layer. So my first suturing will be mucosa to mucosa. So now I'm going to do it like a normal continuous suture. Okay, so just nothing special about it. Identify your mucosa, stretch your mucosa, go through and through. Okay, 1. So this is my first throw, right? Continuous suture, right? My first bite. Sorry. Okay, 1, right? 1. So I'm going to do my second. Second. So I put a small knot here. Okay, so now everyone have a look. Okay, so this is my third throw, right? My third knot or my continuous suture. So when you do a third knot, I pull. You don't pull the whole knot, right? You keep a bit of a residual of the suture available. You don't pull the whole thing. Keep some available, yeah? Keep it loose. Keep some available. So you have a little bit over here. So that will allow you to tie. So you then tie to this loose part. This is how you throw your knot after three bites, like a normal knot. 2, 3. Okay, I've already done the knot. I don't cut it first. Later on, I'll cut this. Don't cut it first. Now I'll now continue with 3 more bites. So just continue 3 more bites. Tie a knot. 3 bites. Tie a knot. 3 bites. Tie a knot. Okay? Okay, now continue with 3 more. Usually I have an assistant to hold a suture for me out so I can see the mucosa. 2.
Esophagus.
So we just trying to mimic closure. Okay, so I've done 3 knots. So I don't pull the whole suture. I leave some slack suture, so then I can then tie it towards it. So this is how you tie every 3 knots. and then you continue another 3 more knots, and you tie. 3 knots, tie, until you go to the other end or until you meet your colleague in the middle, right? Okay everyone, so now I've completed my mucosal layer. I dah matikan on the other end. So the loose end of my suture, this extra bit, I can then cut it off. Loose end, I can then cut it off. Okay. The other end also I can cut it off. Okay. So assuming I'll be closing in 3 layers, so my next layer will be your serosal layer. So same thing. I will start at the apex, so I look for the defect. So the apex of my defect, 0.5 centimeters, is around this area. So I'll take one bite and tie a knot at one bite. Okay, this is a serosal layer. Sometimes it's very difficult to differentiate between your mucosal and serosal layer, so you close in 2 layers. But if you can differentiate, you try to close in 3 layers. Okay. So my serosal layer, I'll take one. I will matikan my suture. Okay, I've done that, and I'll put my archiforceps again on the loose end. So when I put archiforceps, you can pull, it will create tension so you can see the layer. So again, I will continue 3 bites on the serosal layer, and then I will tie. 3 bites, I will tie. 3 bites, I will tie. Same thing. So continue. That's 1, going to do. Okay. That's one. So when you close your serosal layer, you shouldn't see the sutures of your mucosal layer already because the serosal is supposed to cover the mucosal sutures. So then you know you got good closure of the serosal layer. If you still see your mucosal sutures, then you didn't catch properly. Yeah. So this is my mucosal sutures underneath. So I'm gonna bite more serosal right now. Yes. Oh, sorry. So this is my suture, this is my mucosal suture, right? I'm supposed to close it. Alright, can I just have your attention? So the reason why I told you to pay attention earlier on was because I want you all to suture nicely, correctly, because towards the end of the day today, we have prizes for the 3 best participants who suture the best. So try to produce the best work as you can. Alright, we'll give prizes for 3 participants who sutured the best. So show us your best work. So there's a question by a few of you all. How do we differentiate mucosa and serosal? In a real life human, it's easier to differentiate. In this esophageal specimen, you can, but it's a bit difficult. I'll try to show you all again. So I'll create another defect. So this layer which I'm cutting here. So this outer layer is your muscle layer, right? Your muscle layer is brownish, reddish in color. This inner layer is your serosal layer. I haven't cut it through and through, so cut it through and through. So actually cutting a mucosa now. Okay, I have a woman there. Okay, sorry, I've got some food products here. So the innermost layer, which is slightly a bit more yellowish. That's right. The innermost layer, which is slightly a bit more pinkish, as you can appreciate, this is your mucosa layer, very, very thin. In your esophagus sample, the mucosa layer is very, very thin. Your suture might be a bit too big for your mucosa layer, but you can try it. Yeah. If you take a bit of serosa while suturing your mucosa, that's fine. You're not going to be penalized for that. Because sometimes in real life, you'll take a little bit of serosa, so when you try to avoid it. So this thin layer, as you all can see over here, that's your mucosa layer. So if your first layer of suturing is your mucosa layer, you try to catch this layer on one side, and on the other side will be this very thin layer on this side. Okay? This is your mucosa layer. So once you suture your mucosa, you then try to suture your serosa. So your serosa is this whitish, thicker layer. This is your serosa. So your serosa, you suture this to this will be your serosa layer. So if you suture your serosa, you will cover your mucosal sutures later on. So you can't see your mucosal sutures beneath. And then later, when I suture my muscles, I will cover my serosal sutures because my muscle suture will embed my serosal sutures. So it will be like this. Yeah. Okay? So sometimes that is why in some centers, because it's very difficult to differentiate the serosa and mucosa, some centers they close in 2 layers. They'll catch serosa and mucosa 1 layer, and they catch muscle in 2nd layer. But if you want to be meticulous, better to close 3 layers. So what is your take-home points for your pharyngeal suturing is, you try to close in 3 or 2 layers, you use continuous suture technique, but you tie your continuous suture every 3 to 5 sutures. This is to make sure that in case there is a defect in your suturing or in case there is a defect in your pharynx, you will not compromise the integrity of the whole anastomosis. So once again, towards the end of the day, you will choose 3 guest participants and rate pricing if you want, cash money if you want. So 3 of us.
Kalau yang last night untuk matikan siram buat macam ni juga. seal biasa, knot biasa je. Seal macam tu, sama je. Knot lepas tu semua kena cut.
Cut kan.